This is an echocardiogram from the subcostal view. You can see the liver shadow here, and this is the border of the diaphragm. And the cardiac chambers seen here are right ventricle and left ventricle, not very clearly seen in this still image. You can see the left atrium, right atrium, and part of the interatrial septum. In this view, the ultrasound beam from the transducer located above is coming perpendicular to the interatrial septum, and it is parallel to the Doppler signals. For a good visualization, in Doppler you need the beam to be parallel, and in 2D echo you need the beam to be perpendicular. So in this view, both are ideal. If you see an echo dropout in the interatrial septum, in the apical four-chamber view, that may be a false dropout. But if you see a dropout in subcostal view, that will be a true dropout. So we have a defect in the interatrial septum, and we can also see a red color flow here. The color flow is going from the left atrium to the right atrium because the transducer is located in this place, and when the flow is going in that direction, it will be coded red. A reverse flow will be coded blue in this view. So this is a left to right shunt, and ideally it should not be called a PFO flow because PFO by definition is a valvular opening which will shunt only right to left. But PFO can shunt left to right when it is stretched open. If the left atrial or right atrial pressures are higher, the PFO can be stretched open, and then there could be different shunt. Suppose the left atrial pressure is higher and the PFO is stretched open, then you can have a left to right shunt across the PFO. Otherwise, PFO shunts only during certain phases of respiration or cardiac cycle or with Valsalva maneuver. That's why we may use these maneuvers to make out shunts. This is especially done when instead of color Doppler, you use saline contrast echocardiography. Agitated saline containing tiny air bubbles can be injected into the lower limb vein, and from the lower limb vein through the inferior vena cava, it can be directed preferentially across the interatrial septal defect, that is the patent foramen ovale. From the right atrium, it can be directed across the valvula patent foramen ovale into the left atrium. So if a contrast injected in a lower limb vein or even upper limb vein is getting into the left atrium with the agitated saline bubbles on 2D echo itself into the left atrium within 3 cardiac cycles, that is indicative of a PFO right to left shunt. This is important in cases of obscure stroke where paradoxical embolism of thrombi originating from the venous system into the systemic circulation and maybe causing stroke, then that is important. Usual atrial septal defects shunt from left to right because the left atrial pressure is more than the right atrial pressure, and moreover the left ventricular compliance is less than that of right ventricular compliance. So blood from the left atrium preferentially goes across the atrial septal defect in usual atrial septal defect. So the difference between PFO, patent foramen ovale, and ASD, usual ASD is usually mentioned as direction of the flow. Then in long-standing cases with large atrial septal defect, and reversal of flow due to pulmonary hypertension, there can be right to left shunt in large ASDs, that is ASD Eisenmenger syndrome.